refractive surgery, and again, I feel that refractive surgery is something where you just can't afford to go wrong, and that's what makes it so very critical. And I've divided some of the lessons that I learned into pre-operative and surgical, or during the surgery, or post-operative lessons. For example, now this was a 24-year-old female actually. She presented after uneventful LASIK, and on the first post-op day, I was shocked to see this appearance. It looked like as if sand has been thrown into the interface. There was a haze of the cornea, and patient was complaining of blurring of vision. And this is a close-up of that patient's eye, and you can see this fine granular kind of a thing. You don't know what's going on. Is it infection, or what is inflammation, what is going on? So this is a case of sands of Sahara or diffuse lamellar keratitis. Another case, you could see there's some kind of a haze, which was seen in the patient's interface, and patient was complaining of blurring of vision. And this patient actually was a patient of pressure-induced stromal keratitis and not DLK. So these are important things to differentiate. Classically, the PISC which presents after a few days, typically there is some debris or something in the interface, and we give more frequent steroids. Patient is a steroid responder and turns out to be having a high pressure, and the fluid vacuoles they collect in the interface, causing that kind of an appearance. Another case which I had many years ago, and this was a patient on the first post-op day presenting with bilateral infiltrates, in the interface. You don't know what to do with them, whether to treat them with steroids or antibiotic. Are they infective? Are they non-infective? So this is a case of a peripheral non-infective kind of keratitis in a patient of LASIK. And why it happens, I'm going to just address a few factors, because that's what is critical when it comes to establishing a refractive practice. So we have to maintain the sanctity of the work environment and the work culture at in a refractive setting. Preferably the refractive OR, if we can afford it, should be separate from other operating spaces. And we have to standardize protocols, how we sterilize, how we clean the instruments, who's cleaning it, so that in case anything goes wrong, we don't end up with a small epidemic of patients. And it's easy to identify and restrict the issue. And also we have to decrease the variables as much as possible and standardize the consumables, instrumentation stuff. So these kind of cases, they teach us a lesson never to take refractive surgery for granted. The problem is that many times we just assume that patient is going to be 6x6 in the next post-op day. This is especially true when there are multiple users, multiple people coming in and doing the fragment. So in this, the lamellar debris, we have to make sure that it can come from all kinds of oils from the lid margin. There can be particles from sponge, mucus, some fragments. In case the blade is used, it can be blade fragment. There can be bleeding in patients of contact lens users. So many things, lashes, lint fibers, and bacterial toxins. So many things can precipitate this kind of a reaction in these patients. And it's important for us to have a nice and stable practice when it comes to each and every patient who's undergoing surgery. Another patient following LASIK surgery complained of foreign body, decreased vision, ocular discomfort, which was progressively increasing after LASIK. The ocular surface disease index was 33. And important to stain these patients after cataract surgery. It's important that we stain and see. So this is a classical case of a post-LASIK dry eye. And in one of these patients, if we, see these patients, they sometimes have multiple partial blinks, or they would have some kind of a deficiency of meibomian glands or some kind of lesions which would actually be precipitating this. So it's very important that in patients who are undergoing a workup for refractive surgery, like in the center one, I'm showing that 30% of candidates for refractive surgery have dry eye symptoms, and perhaps 50% of the patients who become symptomatic have dry eyes prior to surgery. And here, a surgical procedure like SMILE goes a long way in improving the patient satisfaction after cataract surgery. So we must address the dry eye before surgery. There are publications which say that you do a lipid in every patient of refractive surgery. I think that's carrying it too far, but we must very objectively try to analyze. We have gadgets now which can give us a very good idea of the status of the tear film before we operate. Intraoperatively, choose the right procedure for the patient. There are so many refractive procedures which are available, and you know, so when to convert a patient to, say, for example, implantable column lens, and not going for a PRK or a refractive surgery when the cornea is not fit, when the topography is not allowing it. We have other ways. Go ahead, learn to say no to these patients, right? Optimize these procedures, optimize the settings for yourself, and optimize your dissection techniques, how you do it, so that you are able to achieve the best results in these patients and avoid complications. Careful counseling goes a long way in ensuring that these kind of complications don't happen. This 35-year-old patient came with a refractive error in the right eye after the LASIK surgery, and this is the pentacam of the patient. So this patient had a post-LASIK ectasia. Again, practices which show us that to increase the safety of the procedure, there are different ways. Corneal biomechanics, I feel, is very, very important in correlating to the risk of ectasia. There are a risk ectasia scoring systems. I won't go into detail, but this is something which I learned the hard way, that we must look at systems and risks to the patient before operating on them. So to conclude, with experience and proper precautions and setup, we can make refractive surgery so much more safer than it is. And meticulous workup, operative setup, teamwork and SOPs are essential to ensure part of the success. Thank you very much.
Thank you, Professor Gupta. It's really the expectations of a patient of refractive surgery are much more than any other surgical aspect of it. So if there are any other questions for Professor Amit, you're free to ask. We have some time. Anyone? Thank you.